Thank you very much for this very warm welcome and for this very nice introduction. There's nothing else like it. This is the first time that I am in Asia at all. And I've never been in India, and I'm very impressed about this country. I feel very honored, and thank you very much for the invitation and that I'm allowed to be here to talk about my famous topic. I'm working on low flow and minimal flow anesthesia since 1994. So even when I still was studying medicine, I started to do research using the circle system. And the main topic of my talk today is the circle system and how to use the circle system in the new machines, for example, in the Primus from the Draeger company or in the Zeus from the Draeger company. And I use the Primus since 2003. So one of the first machines which got delivered was delivered in my department, actually the fifth, the second, and the seventh. And right now I have 11 Primus machines in my department and running everything with Primus and Zeus. I will give a very brief and very short overview about the circle system and about pharmacodynamics and pharmacokinetics of volatile anesthetics. And then after that, I will go into clinical practice. And I will explain my clinical practice, why we choose, for example, a special oxygen concentration. And I will give you some, let's say, and standard operating procedure, how to perform it. And at the end, I'm more than happy, and I will stay as long as you like and discuss everything what you like with you and answer all the questions and hope that I get a lot of input from you here in India. Thank you for the nice CV. Actually, there's nothing I can add to this. So my name is Christian Hönemann. I'm a medical doctor, and it's different in Germany. You don't get the MD just with the studies. You have to do a doctoral thesis. So you have to write a research paper and publish that paper. And my paper is published in the European Journal of Anesthesia in the year 2001. And the topic was low flow and minimal flow anesthesia with the laryngeal mask. And it was together with Professor Van Aken, Professor Möllhoff, Professor Prien, and Professor Baum. And then after I finished my medical studies, I went to the University of Muenster. And then I did clinical research. I did work with the TCI, invented for propofol administration. And then I did my research fellowship on local anesthetics, local anesthesia, and minimal flow anesthesia at the University of Virginia in Charlottesville, Virginia, in the US. And then I went back to Münster, had my own lab, and then after I got the possibility to get back to the roots, back in my home country, in my home city where I'm born, to Vechta, I chose that position, and since 2003 I'm running this department as a chairman and head of the department. We are running 5 ORs. We have 14 intensive care beds. We have 18 recovery room beds. We have 2 emergency physician tracks, so trucks where the physician goes out. And we have a 24 hours pain service for acute and chronic pain. I'm a member in the German Society of Anesthesiologists and in the European Society of Anesthesiologists. I'm the Secretary of Finances in the Anesthesia Society in Bremen. So this is Professor Baum, and he worked on minimal flow from 1983. And when I joined him in 1994, he looked like this. And we always were thinking like this about this topic and how we get that more clear and how we could, do more innovations using a circle system. And we produced a CD-ROM. It's a low-flow anesthesia CD-ROM, and everybody who would like to have a CD-ROM, he can send me an email. I give you an email on the next slide, and I will ship this email to you, to everybody, and it's free of charge. So if you are interested in this, everybody which I tell, you can see on this CD-ROM, and then you can try it in a model, so before you start using it in patients. But you can also start using it in patients. It's not dangerous at all. So if we talk about low-flow anesthesia, we have to talk about anesthesia machines. And anesthesia machines are not only just machines to deliver anesthesia, they are anesthesia working places because they cover different things which they have to do. One of the things they have to do is the monitoring for patient safety. And the monitoring of the anesthesia machine divides up in 3 parts. The one part is the hemodynamic parameters and monitoring of the hemodynamic, which is heart rate, blood pressure, oxygen saturation, and the respiratory parameters, like respiratory rate or peak or PEEP, and the gas monitoring, which is very important if you use low flow and minimal flow anesthesia techniques in your circle system. You have to measure the gas monitoring, you have to measure end tidal concentrations of CO2 and the anesthetic gas. Then the anesthesia machine has an anesthesia system, which is normally today is a rebreathing system. It's not an open system, it's a rebreathing system. And you will see you can open this anesthesia system as an open system, as a semi-open, semi-closed, and a closed system. And I will define the different variations of use of the system a little bit later during the talk. And the anesthesia machine exists also, and there's included a ventilator with different ventilatory modes like IPPV, pressure-controlled modes, or spontaneously breathing modes like CPAP, or biphasic positive pressure ventilation. So if you define the anesthesia system, and this is really important if you talk about low flow and minimal flow anesthesia, the anesthesia system is a system that connects interactive. That means it has to heat the dried and cool air gas coming out of the plug at the wall. And also it has to humidify the air, which we deliver to the patient, and then deliver this warm and humidified air to the patient and connect the patient to the anesthesia machine. That is what an anesthesia system does today. And this is all included in one workstation, in one place. So the functional aspects of an anesthesia circle system, sorry for that, is it produces an inspired gas mixture from oxygen, air, nitrous oxide, and the inhalational anesthetic. And it transfers the anesthetic gas mixture from the anesthesia machine to the patient. It has to eliminate exhaled metabolized products like carbon dioxide. And it divides the narcotic gas mixture inside the anesthesia system from the room air outside. So it's important for me that I stay awake because I am the best monitoring of the patient and the patient has to fall asleep. Therefore, I have to divide these two things. I cannot do this with an open system or with a system where I have a valve control system or a flow control system. And the system has to humidify and warm up the inspired anesthetic gas mixture. So how is this done? The first time this technique of preparing an anesthetic gas mixture is the first time mentioned by Ralph Walters in 1924. So what he tried to do is he connected the patient here with a mask A with a tubing system to a carbon dioxide absorbent. So at that time this was sodium hydroxide. And then he had a big bag, it's a reservoir bag, and here he prepared a mixture of laughing gas or nitrous oxide and oxygen. So if the patient inspired this from this bag, the patient took off the oxygen out of this mixture and exhaled carbon dioxide, and this carbon dioxide is then filtered in the system, and with the next inhalation, the patient would rebreathe what he exhaled before, and this actually is free of carbon dioxide. Everything else is not filtered in this carbon dioxide filter. So this is the first experiment in 1925 by Gödel at the ASA meeting, because nobody believed that it really would work. So he put his dog to sleep, he put an endotracheal tube in the dog, he connected a CO2 absorber to the tube, and here is the bag with the laughing gas and oxygen mixture. And the dog was spontaneously breathing underneath the water surface and during the whole talk. And after the talk, he disconnected the bag so that the dog don't rebreath anymore, so the breathing stopped. The dog woke up, he put off the endotracheal tube, and everybody was happy. And this was the start of using rebreathing systems in clinical practice anesthesia. Today it's different. Today we have this circle system. It's first time described by Gauss and Wieland, and this is very important to understand what we do if we use the new machines like Primus with low and minimal flow. So let's go through this one time. Here is the reservoir bag. This is the face mask which is attached to the patient. So if the patient exhales, the gas goes through this tubing, through the expiratory valve, and then the expired gas is stored in that bag. And with the next inhalation, this exhaled gas is going through this tubing. The expiratory valve closed at that time, and the inspiratory valve opens, and then is mixed with the fresh gas at this point, filtered out here in this absorber system. The carbon dioxide is filtered out of the inspired gas, and then the patient inspired the same gas that he has expired the time before. This is the simple system of the circle system. So this is like a flow diagram which you could, make it a little bit more easy. So here's the patient. If he exhales through the tubing, and the exhaled air is stored in the reservoir bag. And if the reservoir bag is filled up, everything else is waste gas. So it's going out of this area with, they call it waste gas valve. And this is opening up, and everything which you give more than the patient really needs is going out through this valve. With the next inhalation, the air which was exhaled by the patient is rebreath? Okay, it's inhaled again, mixed with the fresh gas, and then he is inspired by the patient. So this is the circle, and that's why it's called circle system, because in one direction, valve controlled, the anesthetic gas mixtures circles in the system. So why is the carbon dioxide absorber so important? It is so important because the chemical reaction of carbon dioxide with calcium hydroxide eliminates carbon dioxide in the expired gas and results in humid and warm anesthetic gases within the circle system. Because if you look at this chemical reaction, carbon dioxide and calcium hydroxide reacts to calcium carbonate and water and heat. And it's a lot of heat. If you do low flow or minimal flow anesthesia, you are able, without getting any energy in your system, that the gas is warmed up within 30 minutes up to 32 degrees Celsius. So you have really warm inspired gas. It's very important. And the humidity in your system goes up to 80% within 30 minutes. So you have really humidified and warm respiratory gases within your anesthesia circle system. So let's try and put this normal circle system in a new machine. Okay? This is my coworker Richard, anesthesia nurse, and he is the head of the anesthesia nurse department. This is Bernd, and this is one of our 11 primers. We have them in all places where we do anesthesia, in the OR, in the ready room, and in the recovery room. We have them in all places, with our 2 places where we have ZEUS. We have this monitoring from Gregor, and we have here the respiratory monitoring, and here after Richard you see, behind him, there's this circle system. So let's have a look what happened in the Primus. So I have a small videotape, and I hope that it works. Let's see, okay? It's important to understand that this really is included even in the new machines. So here, This is a gas flow diagram of the Primus machine, which is standing on the left and on the right side of the screen. This is now controlled. This is spontaneous ventilation. So in this mode, this is spontaneous ventilation. As you see, this is the expiratory phase. Now it's the inspiratory phase. You see in the back, I know it's a little bit hard to see. If it's too far away, please come up. I have a lot of videos in my talk, so maybe it's worth it to come a little bit further. So this is the exhalation, and this is now it switches. You see the inspiration. So now it's the inspiration. The lung expands. The air is taken out of the bag, going through the open valve, and now it's the exhalation already. Then the gas flows through the open expiratory valve and is stored into the bag. Inspiration again, the inspiratory valve is open. This one is now open during the expiratory phase. It's important to see, but as you see, it is still a circle system. It's nothing different than the one already invented in 1925. Here in blue, these are two different compounds which are added to the circle system. This is one. First one on the right side, that's the gas delivery system, and here there's the ventilator. So now I switch in a different mode, and you see what happened if you switch the machine on controlled ventilation. So the ventilator works now, so now it's filled with gas. Now it comes the inspiratory part, or this expiratory part, as you see. Now it's the inspiratory part. So the ventilator gives the gas to the patient, expiratory part, the expiratory valve is open, it's stored in the bag. Can't even talk as quick as it goes. Now it's open again, now it's inspiratory again, and now it's the expiratory phase of the breathing period. So as you see, it's the same as it was in the past. So let's then see what we can do with these things. So now we have had a look in the circle system of the Primus. The breathing system can use in different ways. If you use a very high flow of oxygen or of fresh gas flow, a very high flow of fresh gas, like 6 liters per minute, only 10% of the expired gas is really needed for the ventilation. The most of the gas which the patient inspires is fresh gas. So the waste, the amount of waste gas using very high flows is about 90 to 95%. So if you take, for example, sevoflurane, you only use, if you use a fresh gas flow of 6 liters, you only use 5% of the gas, and 95% of the gas in each breathing cycle goes through the waste gas valve out with the tubing to your chimney. As soon as you reduce the fresh gas flow down to at least 1 liter per minute, then you have a rebreathing volume of 50 to 55%. And as more you reduce the fresh gas flow, as higher is your rebreathing volume. So that means that the waste gas amount is less. So if you use a very high flow, fresh gas flow, we call it an open system. That's a high fresh gas flow which is above of 6 liters per minute. And there you have no rebreathing at all. That means no heating, no humidity, and a lot of waste gas. It's not good for the patient. You have the semi-closed system. You reduce your fresh gas flow, and the flow is between 0.5 and 6 liters per minute. There you have a partial rebreathing. And then you have another possibility. You reduce your fresh gas flow even lower than that, down to 1 liter per minute. We call it low flow, or minimal flow is if you reduce the fresh gas flow down to 0.5 liters per minute. And if you go further on, reducing the fresh gas flow lower than 0.5, we call it closed circuit or closed system or a metabolic flow. A lot of anesthetic gas. That means you have a safeness, or you can save between 70 and 90% of the costs which you normally have by buying sevoflurane, indesflurane, or isoflurane. As lower the flow, as better as the climatization and the humidity of your anesthetic gases. You will see that if you do low flow anesthesia, you always have some water in your circle system. You can find water in the tubing. It's not bad, it's a good sign, it's a very good sign. Doing this is very good for our patient because the mucocilliary clearance is better if you have warm and humid air which you inspire. And there is lots and lots of evidence that if you use dry air for your anesthesia, that this clearance goes down for up to 48 hours if you perform an anesthesia for just 30 minutes with very high fresh gas flow or with to 1 hour. And if you use very low flow, you have a very low waste gas, very low pollution of the environment, which is very good for our nature. And because all the gases we use, nitrous oxide, isoflurane, sevoflurane, they are all greenhouse gases. So it's very good if we as physicians save this and don't push the greenhouse effect by using too much anesthetic gas. So if you change from an old machine to a new machine, there might some things happen. I need the audio.
Saatte uuden kärryn. Pitäkää huolta siitä. Volgens mij is het gebroken.
So I think we should think about what we do. We shouldn't do everything all the time, all the same, just because we do it all the time and it works all the time. Maybe if we change just a little, things don't work that well. And that's why I would like to explain what I think is very useful by using the circle system. Let's think about the uptake. What needs a patient? What needs a human being to stay alive? So we need oxygen, everybody knows that, and the oxygen you can calculate with the formula which is done by Brody. It's very complicated. Everybody has an iPhone in his pocket and you can plug it in, but it's much more easy if you just remember. It's about 3 to 4 mils oxygen per minute. That's all you need. So let's say I'm 100 kilograms body weight, that's my size, so I would roughly need 350 to 400 cc's of oxygen per minute, nothing more. Nitrous oxide, I will show it to you. It's a formula of Lowe, which in the beginning of the anesthesia, we need like 1 to 2 liters in 1 minute. But after 15 minutes, we only need 100 to 150 cc of nitrous oxide. So this is like a formula. And then you can also calculate the amount of anesthetic gas. Don't worry, you don't have to do it if you don't want, if you want to use a circle system. But I want to explain where is the reason to do this. What is the rationality behind the technique? So if you use that formulas, you can calculate the amount of anesthetic gas which you have to use. Let's take this 75 kilogram body. So he uses, after 30 minutes of anesthesia, 250 cc's oxygen per minute. And he needs 130 cc's of nitrous oxide, if you use nitrous oxide, and 12.1 cc's of the anesthetic gas, nothing more. So if you count that out, you'll come up with 389 cc's of total uptake of this 75 kilogram patient. So if you use 6 liters of fresh gas flow, who is using 6 liters per minute every time during his cases? I normally use 0.35 liters per minute, so How much do you use? What? 2 liters. 1 liter. Okay, so you do low flow and you do high flow anesthesia. So if you, for example, use 2 liters for a 75 kilogram person, you have 75% waste gas. So you only use 25% of the gas which you actually spent. You pay for it, but you only use 25% of it. The other gas is wasted. And the money is just going up in the air. It's just gone. It's away. Abbott takes the money. I don't think Abbott should take the money. I think we should take the money. It's better. So if you have a small child, like a 10 kilogram child, this child needs just 90 cc's as total gas uptake in a minute. 90 cc's. So if you do 2 liters per minute, then you have waste gas, which is about 95%. So you only use really just a small bit amount of sevoflurane, but you pay 20 times more for the same, for just the same. And I would try to explain this to you, and maybe some of you will switch their technique and do it what I would like to explain. So this is the uptake of gases during an inhalational anesthesia, and the gas which is calculated over here is isoflurane. Don't worry, it looks complicated, it's very easy. The white thing here, this one, this is the oxygen uptake. And as you know, the oxygen uptake of a human being is always the same, is not varying. Sure, it's varying if I'm running 100 meters. But if I'm sleeping during anesthesia, it's always the same. So here in this example, it's around 240 cc's. The blue, that is the uptake of the nitrous oxide over time. So here, this is the time scale, and this is the amount of uptake of the gas in liters. So you have an uptake in the first minute of about 1.4 liters of the nitrous oxide, but after 15 minutes you are down to 250 cc's, and after 30 minutes you are down to around 130 cc's, and then at the end, and as longer the case, as lower the uptake for the nitrous oxide. And here you see that you have a high uptake of the anesthetic gas only in the first minutes of anesthesia. And after that time, after this wash-in time, you have only a very low uptake of the anesthetic which you use. So altogether it comes up, for this example, after 120 minutes, that we only need around 400 cc's per minute if you use nitrous oxide. So can we make that better? So let's think about why should we use low flow anesthesia technique. If we do that, we can save a lot of money. It saves volatile anesthetics, that increases the efficacy of the volatile anesthetic which we use, and this decreases the costs and saves up to 90% of the money we spend for the volatile anesthetic. That's a lot. And optimizing anesthetic gas climate due to increased humidity and increase in temperature of the inspired gas is very, very good for our patients. And the decrease of waste gas decreases pollution of the environment, and this decreases the greenhouse effect of volatile anesthetics, and that's very good for the nature. So we should use low flow and minimal flow techniques. So I show you the first example of how to practice this with a Primus, for example, as an anesthesia machine. So you do a premedication. In Germany, normally we do always give a tablet of benzodiazepines. You don't have to, but if it's just our routine, then we introduce anesthesia with whatever you like: propofol, ectomidate, thiopentone, opioids, muscle relaxants. You can intubate the patient, or you put in a laryngeal mask, you can do a face mask, whatever. And then you need an initial phase with a high flow, with a high fresh gas flow. In the beginning, you start up with 1.4 liters per minute oxygen and 3 liters per minute nitrous oxide. And then you start up with isoflurane. This is the vaporizer concentration which you dial in. Okay? So if you use 1.4 liters of oxygen and 3 liters of nitrous oxide, this comes up to 28% of oxygen. You can do your calculation at home, but it comes up to 28% of oxygen. And this is the dialed-in concentration of the iso-desflurane, and this is also around 0.9 meg. So if you dial that in. So what happened to the concentration in the circle system, which we measure? So this is the exhaled concentration of oxygen, the exhaled concentration of nitrous oxide, and the exhaled concentration of nitrogen. Because normally our body, right now, in my body, 79% of what is and gases dissolved in my body is nitrogen. So with the pre-oxygenation, by giving for 3 minutes 100% of oxygen, we just blow out the nitrogen. So this is the inspired oxygen concentration in the circle system, and this is the nitrogen concentration in the circle system. We have to wash out the nitrogen, and we have to wash in the oxygen. So after we did this, we induced the anesthesia, and then we put up 1.4 liters of oxygen and 3 liters of nitrous oxide. So then you see that nitrous oxide concentration is increasing very quickly within the circle system, and the nitrogen stays low, and the oxygen concentration reduces, it decreases down to 28% over time. So this is the high flow phase of the minimal flow anesthesia. So what happened with our volatile anesthetics during that time? So here are the examples. This is the wash-in of different anesthetic agents with 4.4 liters of fresh gas flow. So 1.4 liters oxygen and 3 liters of nitrous oxide. There's always 2 lines. Why are there 2 lines? Because it's an inspiratory concentration and an expiratory concentration. So always we take the lower line. This is expiratory. This is what we need. So this is the concentration for sevoflurane. So this is the expired concentration of sevoflurane in our system if we use 4.4 liters of fresh gas flow. So here's 1 minute, 15 minutes. So within 15 minutes, we have an expired concentration of sevoflurane of 0.9 meg. Okay? After 15 minutes, we washed in our anesthetic gas. The same counts for isoflurane. The same counts for desflurane. So after 15 minutes with this high flow, we have 0.9 meg. This is the amount of anesthetic gas which I would like to establish within my circle system. So this is the initial high flow phase, and what we have to do during that period is a sufficient denitrogenization. We have to wash in the wanted nitrous oxide concentration of the anesthetic gas in the circle system. We have to establish the wanted concentration of the volatile anesthetic, and also we have to have a complete filling of the reservoir bag. So if this is established after 15 minutes, we can reduce the flow. So what are we doing then next? So this is again, when do we reduce the flow? We reduce the flow if this all is done. Denitrogenization is done, anesthetic gas concentration is established, and the fresh gas volume is okay. And the reservoir bag is still filled. So then we reduce the flow. So this is then the technique with low flow. So what you do with 1 liter per minute, right? So after the initial phase, you reduce the flow to 0.5 liters per minute of oxygen and 0.5 liters per minute of nitrous oxide. Are you doing that in your practice? Yeah? And then you have to increase the isoflurane concentration at the vaporizer and the sevoflurane concentration at the vaporizer, and you can leave the desflurane vaporizer concentration unchanged. Doing that, you have very stable concentrations. But I think you could go even further than that. If you do a minimal flow anesthesia, then you reduce the flow reduction down to 0.3 liters per minute of oxygen and 0.2 liters per minute of nitrous oxide. So it's still together 500 cc's, that's the fresh gas flow, and you increase the vaporizer setting a little bit higher than with the low flow technique. So for isoflurane 2.5, for sevoflurane 3.5, and for desflurane plus 1% of what you had before, between 4 and 5%. So here's an example. This happened then to the concentration of the anesthetic gas within our circle system. So this is, again, over time. So here starts, and here is 1 hour. And this is the concentration, the expired concentration, the end-tidal concentration of isoflurane, for example. So here we start up. There are a lot of lines. It looks a little bit complicated, but it's not as complicated as it looks like, and I would like to explain it to you. So here, this is the spotted line, right? So this is the line which is spotted. This is the low flow line. That means we start out with a high flow period and then we reduce the flow to 0.5 liters per minute, and the vaporizer setting is down up to 2.5 volume percent. And you see the concentration of the volatile anesthetic within the circle system is very stable at 0.92 mag. It's very, volume percent of isoflurane, sorry, it's very stable. If you use a low flow technique with 1 liter per minute, also, again, you can establish a very stable concentration of isoflurane within your circle system. And this is the technique which you do with 2 liters per minute. You see also with 2 liters you have a stable system. But you use 4 times more anesthetic gas. If you use 2 liters, you have the same result at the end, and you spend 75% of the money which you have to pay for your volatile anesthetic, you just waste it. Okay? So, very important to know. This is an example of what happened. This is an anesthesia. Here is again 0. This is 1 minute, 1 hour. And what I want to show is that the system, if you use high fresh gas flows, is a very quick changing anesthesia circle system. So here we start with the initial phase, and then we work here, as you see, with the vaporizer concentration of 1.5, and we use 4.4 liters per minute fresh gas. So this is the initial thing, the high flow phase. We stay at high flow, and you see that the expired concentration is still going on a little bit. And then after 20 minutes, this was an example which we really measured because we wanted to know what happened to the concentration within the circle. So we turned on the vaporizer, we increased the concentration to 2.5, setting at the vapor, and as you see, a very quick change of the inspired gas and also a very quick change of the expired gas. And then after 40 minutes, the case was done. We stopped the vaporizer, and then the concentration within the circle system is going down very quickly. So I think this here at this point is very dangerous, especially if you use sevoflurane and desflurane, because there's the increase even quicker. It's very dangerous. Here at the end of surgery is very good. So if we really want to wash out the anesthetic at the end of surgery, this is a very good thing to do. So, depending on the fresh gas flow, changes of the anesthetic gas concentration within the circle system are very quick. As higher the flow, as quicker the changes in the system. Or, which is much easier to remember, this is an example with low fresh gas flow. So this is a minimal flow anesthesia, so we are talking about 0.5 liters per minute fresh gas flow. So here's the initial high flow phase. This is again the inspired and the expired concentration. And then after 15 minutes we reduce the flow from 4.4 to 0.5 and increase the vapor from 1.5 to 2.5. And then you have this stable concentration of inspired and expired isoflurane within the system. And then we increase the vapor of isoflurane up to 5%. And then you see how slowly the concentration of isoflurane increases. So when I'm not aware what I'm doing, maybe I'm just a little bit unconcentrated. This is very safe if this might happen with low flow. But this is very dangerous if this happened with high flow. It's very dangerous. So I can't even go to the bathroom. If I do this and I go to the bathroom and I'm coming back, patient is dead. If I do this, going to the bathroom, nothing happens, actually. Let's try this. So this is very important. We have to understand that if we use a very low fresh gas flow, it's very safe for our patient. We have very slow changes of the anesthetic gas concentration within the system. It's very low. So low flow anesthesia practice with oxygen and nitrous oxide, the withdrawal. Now, I want that the patient wake up quickly. So there, I have to use 4.4 liters per minute. And because, as you see here, if you turn off the vaporizer, but you stay with the low fresh gas flow, it takes a long time until the isoflurane concentration decreases. So you can turn off the vapor before the surgery is ended. And then, when the last suture is done, then you increase the flow and you see you can wash out your anesthetic gas very quickly. That is exactly what we do. So we close the vaporizer 10 minutes before end of surgery. And then when the surgery is done, we wash out the nitrous oxide with a high flow of oxygen. And then in the recovery room, you can do whatever you like. Doesn't matter. So this is, again, it's a total uptake. So can we make it a little bit more easy? Is there a way that we can use the anesthesia machine even more easy? Yes, we can. I'm not Obama, but it's okay, we can. So here again, the white is the oxygen uptake. The blue is the uptake of nitrous oxide. And here is the uptake of the anesthetic gas. Green line is the line what we do with the low flow anesthesia, right? So we start with 4.4 liters, which is up here somewhere, and then after 10 minutes we reduce the flow down to 1 liter per minute, and it stays at 1 liter per minute. And everything what you see here in gray is wasted. You don't need it, but you have to pay for it. If you do a minimal flow anesthesia, which is 1 liter per minute, you know, the gray, what you waste, is much less. So let's think about doing this without nitrous oxide. So this is the same patient, and we anesthetize him without nitrous oxide. We don't need really nitrous oxide. It's just we think we need it, but we don't really need it. We can just, what nitrous oxide does, like a little bit analgesic effect, we can give a little bit more opioids, and you are safe at the same time. So without nitrous oxide, the uptake, the total uptake of the patient is even less than with nitrous oxide. So as you see here at this point, the uptake after 10 minutes is around 250 cc's, maybe 300, but not more. So you could do a flow reduction earlier, or you could use lower fresh gas flows, and I would like to show you what we do right now. So this is then a low flow anesthesia with an oxygen air mixture. I'm always asked, if you have to use nitrous oxide. I think no, but I will explain it to you why we don't use it anymore. So this is oxygen air. The initial phase is the same, 10 minutes. You put in 3 liters of air and 1 liter of oxygen in the fresh gas and 2.5 volume% of isoflurane for 10 minutes. And this is sevoflurane and desflurane. You need a little bit more because you don't have the nitrous oxide, or you have to give a little bit more of opioids. If you reduce then down to 0.5 liters per minute, you turn the oxygen down to 0.3 liters and the air down to 0.2 liters per minute, and increase the setting of your vapor for isoflurane and sevoflurane up to 5% and for desflurane up to 8%. If you do that, you establish exactly the same concentration of isoflurane or anesthetic gas in the system than you would do with nitrous oxide. So here's the example. This is isoflurane. Here again, an anesthetic. It's an anesthesia starting at 0, and this is 1 hour. We have the high flow period, which is here. The dotted line is the vaporizer setting, okay? So here you have the dotted line. We start at 2.5 liters per minute with 4 liters. And then here at this point, we increase the vaporizer up to 5% and we decrease the flow down to 0.5 liter per minute. And you establish an expired isoflurane concentration, which is exactly 0.9 meg. Nothing more. So you don't waste anything. This is a very good thing. So you could pretty much do a nearly closed circuit anesthesia. So you really only give what the patient really needs. Oxygen, which is metabolized, and the anesthetic gas, which is metabolized or vaporized over the skin. But it's very, very low gas which you really lose during anesthesia. Who's doing this? Somebody doing this in the audience? Nobody, okay? So this is the part which we cannot really, exclude. We have to give a high flow phase, at least if we use isoflurane. But maybe with the new gases we can do better. With sevoflurane and desflurane we maybe do better. So let's do an anesthesia with a nearly closed system with oxygen and air mixture. So we start up again with the initial high phase, which is the same as I showed you before. And then you do a flow reduction, but you don't give any air. You just give the oxygen, which is used by the patient, the uptake of the oxygen. And you give the uptake of the anesthetic gas, nothing more. Okay? So now you do walk with a fresh gas flow of 0.3 liters per minute. And you have a very, very constant end tidal mag. Yeah? You had a question? Okay. So let's do a calculation. We are talking about the efficacy of decreasing the fresh gas flow. So the efficacy decreases with increased fresh gas flow. That means if we do a high flow anesthesia with 4.4 liter per minute with nitrous oxide, we only use 7% of the volatile anesthetic. The rest is gone and wasted. If we do a low flow with 1 liter per minute, we only use 24% of the anesthetic which we use. If we do a minimal flow with nitrous oxide, we use at least 40% of the anesthetic, so we really have an increasing of the rebreathing volume. But if you do a nearly closed circuit without nitrous oxide, you are getting up to 70% of efficacy, so you use 70% of the anesthetic gas which you spend into the system. So it's very good. Let's talk about cost. This is what anesthesiologists are not aware, but you should be aware. Sevoflurane is very expensive. So if you do a high flow anesthesia with nitrous oxide, you spend about 52 euros, a little bit more than 52 euros within an anesthetic which has a duration of 2 hours. 52 euros times 65 of your currency is like 50 times 65 is 13,000, is that right? 13,000 ruben per 2 hours. So with desflurane, with high flow, I'm coming up with 45 euros. And with isoflurane, I'm coming up with 11 euros. But if you use a closed circuit and you use the most expensive gas, like sevoflurane, you still pay only 15 euros for a 2 hours anesthetic. So you save 75% of the money by just reducing the flow. So for example, if you would be in charge and you have to buy a new anesthesia machine, okay, and you have two choices. One choice is a machine for 15,000 euros and the other choice is a machine for 25,000 euros. So the one machine is able to use a fresh gas flow of 2 liters and the other machine is able to perform an anesthesia with a fresh gas flow of 0.3 liters. Which one would you buy? And the first thought, you would think, I take the cheap one because why should I buy the most expensive one or the more expensive one? But if you have a second thought, you think, wow, if I do closed circuit, I can use the better machine. I can have all the values of the better machine. I don't even have to pay for it because it pays itself over saving over time. In Primus, in my department, I need 3 years, so I got the payback compared to other machines. And with the CIUS, it takes me 4.2 years to get my loan back. So I saved such amount of money by saving anesthetic gas. So the cost saving is so big that I don't care about what I have to pay for the machine. This is very impressive for me. My department, we spent about 60,000 euros when I started in 2002, when I took over the department, we paid 60,000 euros for volatile anesthetics. Right now we are down to 20,000 euros per year for volatile anesthetics. So I save 40,000 euros every year times 4. It's like 3 Primus. So just think about it. It's very important to save this gas. So what are we doing in Vechta? Now I'm explaining you the technique which we use with a Primus machine. So we had the chance to build a new OR, which is good, but I wanted to save money by building the OR, so I have no tubing for nitrous oxide, and I don't have to pay for the tubing. I have no technical support for nitrous oxide, no tubes, no valves, nothing. I save that money. I have no costs due to service to the tanks or delivery, no cost at all, and I have no pollution of the environment or within the OR. Even pregnant anesthesiologists or anesthesia nurses are allowed to work in my OR because I don't use nitrous oxide. So I don't use nitrous oxide because nitrous oxide is dangerous. This is a case report. This is a newspaper in Germany. This is published in April of 2008, and it is a story which is really harmful, and I would like to explain to you why I stopped using nitrous oxide beside the cost. There was a young woman, I think it's written in here, I think she was 23 years old. She was pregnant and she got a C-section, so she got a childbirth. So she went into her hospital in Hoyerswerda, which is in the eastern part of Germany, and they put in a spinal. Everything was fine, perfect. Spinal worked. They did the surgery, and the anesthesiologist said, I want to do better. I give her a little bit of oxygen in her nose. So he gave her oxygen. So he started with 4 liters. But what he didn't know, the machine was on service on Friday before. So this was on Monday. So during the service, inside the machine, and the anesthesiologist couldn't see that, they switched the tubing of the nitrous oxide with the oxygen. So he thought he opens up the oxygen, but he opened up the nitrous oxide. So the woman got 4 liters of nitrous oxide via the nose. So what happens then? 4 liters of nitrous oxide, very easy. The oxygen drops, the saturation drops, it goes down from 97 to 95 to 90. After a couple of minutes, the woman got a little bit dizzy. You know, she fell asleep. She didn't feel well. The surgeon said, the blood is taking, is really getting darkish blue. It's not good. And he said to the anesthesiologist, here we have an example. This is a pulmonary embolism due to the amniotic fluid. So what is the anesthesiologist doing in that case? He turned off the oxygen even more. Right? So he gave not 4 liters, he gave 8 liters of oxygen. He thought he gives oxygen, but he gave nitrous oxide. So then it's getting even worse. In the meantime, the child was born, and the child was not then connected to the woman anymore. So the child didn't get any nitrous oxide anymore. So the child woke up, and everything was fine with the child. But because the woman right now had a Glasgow coma scale of 3, she got intubated. And they connected the anesthesia machine to the endotracheal tube. And they ventilated this woman with 100% nitrous oxide for half an hour or even longer. Everything was blood pressure, heart rate, tachycardic, blood pressure down, hypoxia, no saturation. And they thought they have a terrible, really terrible embolism. So they disconnected the woman for the transfer of this young woman in the University Hospital. So they had to use a Draeger ventilator, emergency ventilator, and then the nitrous oxide was gone. The woman recovered. Heart rate, blood pressure, saturation, everything was fine. But she died 3 days later because of hypoxia of the brain. This is worse, isn't it? It is really worse. It's just by using nitrous oxide. But now it's getting even more worse. Next case, same day, 2 hours later, same scenario. Woman, pregnant, spinal, put in a spinal, everything fine, starting surgery, putting in the tubing, giving oxygen. They thought they give oxygen, they gave nitrous oxide, and the same happened again. But this time the anesthesiologist has switched. And this guy was intelligent. He said, no, there's something wrong. He changed the machine after a couple of minutes. And then the woman did better, but also the second woman died after a week because of hypoxia of the brain, because of ventilation with 100% of nitrous oxide. This happens all the time. Actually, in Germany, in the German-speaking countries like Germany, Austria, and Switzerland, we have 3 to 5 cases per year who die because people use nitrous oxide, because tubing is switched, or the wrong gas is opened, or the inspired oxygen concentration is measured the wrong way. This is really worse, and that's why I not use nitrous oxide anymore. It's very important. So I use 100% oxygen. So if you use 100% oxygen, you don't plug in the nitrous oxide to the wall, so it cannot happen that you apply nitrous oxide. You only can apply 100% oxygen, or if you switch air with oxygen, then you apply 21% air, but the patient will still be alive, which I think is very important for me, that the patient is alive. It's okay that the patient goes to sleep, but it's more important that he wakes up without any harm. That's important for me. I'm an anesthesiologist and not a killer or a murderer. So, if you use 100% of oxygen in the circle system, it has advantages. And now I will discuss the advantage of giving oxygen in the circle and talk a little bit about oxygen toxicity. It's about 7 to 8 pictures. It's actual research which we right now do. It's very, very new and very interesting. So oxygen perioperative reduces the incidence of surgical wound infection. This is a paper published in the New England Journal of Medicine in the year 2000, and it's still valid. Nobody has shown that this is wrong. Oxygen is good because it reduces the incidence of post-operative nausea and vomiting. So give oxygen, 80%. And you have a better outcome if you do 80% oxygen in the anesthesia circle system for at least 2 hours after colon resection, because you have a better healing of the anastomosis of the colon. So if this is good, so no wound infection, no PONF, no atelectasis within 6 to 8 hours, I show you some pictures, and you will be, I would like to discuss the pictures and the movies with you, which come up later. We are very safe if we don't ventilate the patient. If we have 80% of oxygen in our body, we can at least wait 10 to 15 minutes. We have filled up all the oxygen stores in the body. So this is very good for if you have hyperventilation or apnea. We have less periods of hypoxia, that is known, and we have a very easygoing inhalational anesthetic. So why not using 100% oxygen? If we do that, so we start up for 5 minutes with 4 liters of 100% oxygen, and then we turn down the fresh gas flow down to 0.5 liters per minute. We have a very stable expired oxygen concentration of 0.78 after 60, 70 minutes. So 80%. 80% of oxygen mixed with air in the anesthesia circle system in a closed system. This is measured in the primus. We do this in Vechta in my hospital all the time. So when I left Germany on the 19th at the evening, I looked in our database. All the cases are scanned, and we have all the data. So we did this 69,408 times without any complications, clinical relevant concentrations. So there are contraindications to do that. You are not allowed to do this in neonates with a body weight below 1.5 kilograms. You are not allowed to do this in patients who had an acid aspiration. You are not allowed to do this if you have patients with an extreme chronic obstructive pulmonary disease. And you are not allowed to do this in patients who you are under medication during chemotherapy for example, bleomycin and mitomycin. Then you are not allowed to do this because you got pneumonitis. That is induced by the drugs, by the high oxygen concentration. There are some people who say you are not allowed to do this in laser surgery because it may inflame plastic parts of the endotracheal tube. But people talk also about neurotoxicity of oxygen and pulmonary toxicity of oxygen. That was what we have discussed yesterday evening for more than an hour after the talk. So I thought it's good to give you the data so we can discuss this later on. And you have already the data. And you have a retrolental fibroplasty induced by high concentration of oxygen. So let's go into details. What is behind this? What does neurotoxicity mean of oxygen? So in German, it's a German scientist who found this, is Paul-Bert effect. So this Paul-Bert effect is only if oxygen is used in a hyperbaric situation. So you have to have a diver, he has a diving accident, then he has to have a hyperbaric chamber therapy with a surrounding pressure between 1.3 and 3.6 bars. Then you have a relevant neurotoxicity in adults. And then you have to have this treatment for at least 6 times 4 hours. I think the Paul-Bert effect is not clinically relevant to patients which are ventilated with normal pressure. So let's talk about the pulmonary toxicity. It's French, I think. So you should say that. It's a Lorraine-Smith effect. Is that right? Lorraine-Smith? Or Lorraine? Lorraine, okay. It induces tracheobronchitis, but only if you ventilate 4 to 22 hours with an inspired oxygen concentration of over 90%. And now, this is the best thing in rats. Not in humans, in rats. This is in rats. It's never shown in humans. And is only clinically relevant, that is, empiric. That's what you find in the literature. It's only clinically relevant on ICU with very high inspired oxygen concentration. And then you have the retrolental fibroplasty. It's induced by retinal hypoperfusion. It's only in neonates and only if the body weight is below 1.5 kilogram. And it's also called retinopathia praematurum. So we have a low-level neonatal center in my hospital. We have kids with that age, but this is described for long term. It's not for half an hour. It's not for 20 minutes like a small hernia repair. This is meant for long-term ventilation, long-term treatment in an incubator. Okay, let's think about the hypoxic arterial vasoconstriction. So we wanted to talk about the oxygen toxicity. Are we allowed to use high oxygen concentration? Yes, we are. This is not relevant. It's not clinically relevant. The mechanism is clear, but the decrease in cardiac output is in the same amount as the oxygen concentration in the blood increases. So if you calculate the oxygen delivery, it's the same. So the delivered oxygen is the same. So this is not an effect at all. So, okay, so this is the first time where we can tell oxygen is not toxic. So let's think about pulmonary atelectasis. Also a question always asked if you use high inspired oxygen concentration during surgery with closed circuit anesthesia. There's this article published in British Journal of Anaesthesia, just a little oxygen to breathe as you go off to sleep. It is always a good idea. Yes, I think. The reason is this. These are the original data. Oxygen and atelectasis. Here is the original publication. This publication is done in the Lancet in 1995, and they draw the conclusion from 6 patients. So they did 6 patients, and this is the number, and there they say that you have atelectasis if you use 80% of 100%, 80 to 100% of oxygen during anesthesia. Okay, let's have a look. This is a new publication. This is in 2010. They did at least 30 patients, so it's a little bit more than 6. And as you see, with 60% oxygen in the inspired air in your circle system, you have pretty much no atelectasis over time. With 80%, you have over 40 minutes pretty much no atelectasis over time. If you use 100% in the circle system, which is pretty much impossible, but if you would really try that with fresh gas flow of 18 or 20 liters per minute, then you might have some patients who have clinical relevant atelectasis. But there are other reasons which are more important than oxygen to get an atelectasis. So how do I get the concentration? This picture actually doesn't fit there, so I skip it. So here, pulmonary atelectasis are induced by high inspiratory pressure in one-lung ventilation. This is a problem. Very high inspired pressure. So everybody would say this is the operated lung. So these are both patients, both got surgery on the lung, both got resection, pulmonary segment resection, and everybody would say this is the side where they performed the surgery. But this is wrong. The surgery was done here. You can see that because here are the drains, okay? The thoracic drains. This is a pulmonary edema and atelectasis due to very high inspired concentration because they couldn't oxygenate this patient. The same here, the second one. It's published in Radiology 2002, and I thank my friend Professor Fernandez Garcia from Spain, from the University of Spain, because he gave me that pictures. And also, if you reduce the functional residual capacity, a mechanism of intraoperative atelectasis. So the FRC is reduced by in obese patient, in pregnant patient, if you have a head-down position, and you have laparoscopic surgery, and then if a woman gets pregnant, then the FRC goes down and the amount of atelectasis goes up because of the pressure of the kid in the abdomen. So if I then, during surgery and during anesthesia, increase the PEEP or do a pulmonary recruitment, I can then restore the functional residual capacity, and I have the same situation as before. So maybe that this is a huge problem which we have during anesthesia because we don't use PEEP, or a lot of people don't use PEEP during anesthesia. You have to use PEEP. It's important. I show you why. You also have to use spontaneous ventilation if you can. If there's a possibility to do it. This is a model. I also got these movies from Garcia Fernandez from Madrid. Here you see a small child model. It's a rat actually, but it's a model for a child. And this rat is spontaneously breathing in a CT scan. And you see here that there are pretty much no atelectasis. Here you see the diaphragm, and the diaphragm, sucks the lung, opens the lung. And here, this is the same model, and this is controlled ventilation. And as you see, you have an overexpansion in the upper areas of the lung, and you have atelectasis in the lower areas, in the grade 3 areas, where you have low ventilation and high perfusion. So spontaneously ventilation may prevent from atelectasis, not the oxygen concentration. This is not so important. This may be important, more important, especially if you don't use PEEP. So now, it should go the next picture. Yeah. So this is another example why we should use PEEP. This is an example for a kid. It's a kid lung. This is a CD scan. It's a reconstructed CT scan of the lung. It is a 3 kilogram canine, which represents a 5 kilogram child. It's a model for a child. So this is before induction of anesthesia, and this is spontaneously ventilation. You see the lung is completely filled with air. So everything you see, what is white, is air. So let's see what happened if you intubate this child in this model. You see, you have dorsal atelectasis, lots of dorsal atelectasis, very quickly, just after intubation, because you haven't have the PEEP. The FRC goes down, and therefore you have atelectasis, dorsal atelectasis in this kid. Let's see it in a movie. So this is a movie. It shows the collapse of the lung if you don't use PEEP, in an adult model on the left side and in a newborn model on the right side. So here you see this is the adult lung, this is the children lung, the disconnection. You see what happened to the children? It collapsed completely very quickly. And here you see the collapse of the adult lung, and here is pretty much no air in it anymore. It's completely an atelectasis. See that? Unbelievable. So let's see what happened if we do a recruitment maneuver and use PEEP. So here is the same lung. We use a low PEEP after pulmonary lung recruitment, and this protects against atelectasis and keeps the lung open. Okay? Here, this is the recruitment maneuver with 20, with a PEEP of 20 during surgery. See that? Now it's going down. It's very well inflated, the lung. No atelectasis at all. Very nicely expand. Also the adult lung, very nicely. No atelectasis. And if you look at the screen of the ventilator, you see how nicely it's ventilated? And now the camera turns on the Julian, and you see the PEEP is only 2. So this small PEEP keeps atelectasis away. So you have to wear PEEP. It's very important. You cannot do this with all machines, but Draeger, for example, they have an auto PEEP. So even in the spontaneously breathing mode with the Zeus, you have a PEEP of 2, which is great. It's perfect. So pulmonary atelectasis and its prevention is very easy. Use an FeO2 below 0.85 in the circle system, and then you have no clinically relevant atelectasis. Low inspiratory pressure, PEEP around 3 or higher, especially in kids, and if possible, no disconnection of the system. Lung recruitment maneuver is okay, you should do that, and spontaneously ventilation if possible, with a PEEP. Or with CPAP is also good, or ASB, very good. So which volatile anesthetic should you use for your closed circuit anesthesia? Draeger told me you want to hear something about clinical relevant data, so I give you some data about the pharmacokinetics and dynamics of these three different volatile anesthetic used. Let's talk about the metabolism. As you see, desflurane is metabolized only 0.2%. Isoflurane 2%, and sevoflurane is about 7% metabolized in the circle system in the body, in the human body. It's not dangerous, not toxic, but it's metabolized. But these things, they react with soda lime. Desflurane has no reaction with dry soda lime. But if you use isoflurane, you have also no reaction with soda lime. Halothane, no reaction with soda lime, with dry soda lime, but a very heavy reaction of sevoflurane with dried soda lime. What happened if this happens? Most of the anesthesiologists have these cases. They are always Monday, and they are always in an OR where you don't do regularly, routinely anesthesia. Okay? You have your machine connected to the plug, and there was a surgery on Friday. They forgot to turn off the oxygen. So the oxygen did flow through the circle system for the whole weekend. So then the soda lime dried for 96 hours or 72 hours over the weekend. So you start your anesthesia in the morning, on Monday morning, with the dry soda lime, and it's a heavy reaction with this dry soda lime. So you try to do an inhalational anesthesia with the children, with the child, and the child does not fall asleep. Have somebody seen that? I did see this 2 weeks ago. So you have to change the soda lime and then it works, the sevoflurane works fine. But if you don't use sevoflurane, this may not happen. So always think about it. There is reaction of sevoflurane with soda lime, with dry soda lime. So how about wash-in? What is the quickest anesthetic gas? It's laughing gas or nitrous oxide. The second one is desflurane, so it's very quick. You have very quick inspired concentration of the gas within 2 minutes. Sevoflurane, it's a little bit slower than desflurane. Then comes isoflurane, it's a little bit more slower, and then halothane. So in my perspective, in the clinical routine, this is only relevant when you do an inhalational induction. So doing inhalational induction with desflurane is impossible. You cannot do this, but you can do an inhalational induction with sevoflurane and laughing gas, and that works fine and nicely, if you like it. But it works also with sevoflurane alone, very nicely. Very nice. So what about the wash out? So wash in, metabolism, wash in, and now wash out of the circle system. The best gas for long periods of anesthesia is desflurane, because the washout of desflurane is pretty stable and only takes 10 minutes, even if the anesthesia is longer than 3 hours, 4 hours, 6 hours, maybe 10 hours. The reason is that the solubility of desflurane, the fat solubility, is so low that you have no accumulation in the body. This is different with all the other gases, and if you see sevoflurane accumulates, so you have a wake-up time which about 1 hour if you have 6 hours of anesthesia or 7 hours of anesthesia with sevoflurane with high concentration of 0.8 mg. So the best one would be desflurane. So the practice, what I will show you now, right now, is the clinical practice which we do, and we call it the metabolic flow. So we do the pre-oxygenation with oxygen. We give a little bit lidocaine. Patient fall asleep, whatever I like. And then I use in the beginning isoflurane. So I start up in the room, in the ready room, with 1 liter per minute with isoflurane 5% and an oxygen concentration of 100 in the fresh gas. Why do I do this? It's very easy. The most cost of my anesthetic gas I have within the introduction period. So this is an anesthesia. It's a 3.5-year-old boy, 15 kilogram of body weight. He got a circumcision, and I used a closed circumsystem anesthesia, and at that time, which is 8 years ago, I used the Cicero system from Draeger. So as you see, I spent 11 euros for the first 8 minutes before the kid fell asleep. My kids are not as nice as they always show in the Abbott videotapes. My kids are, you know, they don't want to be there, they cry, they don't want to have the mask on the face, they don't like that. So this is why the concentration in the system goes up and down, because I couldn't get the mask close, right? So I spent 11 euros for the first 8 minutes, and then I went down to the closed circuit, so with 0.1 liters of oxygen and 4% of sevoflurane in the system. And as you see, I only spent another 15 euros for the next 20 minutes. So the most cost you have during anesthesia is in the beginning, in the introduction. So I can do this because I have these very nicely equipped ready rooms. Here's room 2, this is room 3. It's very nicely equipped. I have a Primus, and I have Draeger monitoring, and I have everything on place. It's very easy, very nice. So if you do this, like 5% isoflurane with 1 liter per minute, you have this increase of expired isoflurane concentration, which comes up to 0.9 mg or 1.1% with 1 liter after 6 minutes. Very easy. So here again, the cost. 2 hours high flow, 52 euros. 2 hours minimal flow or closed circuit, 15 euros. So then I go back in the OR. So the patient is asleep. I go in the OR. I use desflurane there. So I switch from isoflurane, from the cheap one to the expensive one. use isoprene, I turn on the vapor on 18% with a fresh gas flow of 0.5 to 0.75. And as you see, after a short time, here is 500 cc's, or let's do this slide is better. So after a short time of 3 minutes, I have 0.7 mag with 0.5 liters of fresh gas flow within the Primus circle system. And if I want to have 0.9 mag, it takes me around 5 minutes with 0.5 liters. So very easy to do. This happens if you measure the concentration in the system. This is the expired desperane concentration, and as you see, it's a very quickly increase of the expired concentration. And here we're not using 0.5, we only use 0.3 liters per minute of oxygen. So it's a very slow increase of desperane concentration in here at the end, then the stable phase, and then at the end, when the surgery is done, the washout of the desperane very quickly, very nicely. So here again, an original picture from the Primus. It's a male, 66 years old, and it's done on the 12th November 2009. Very easy. This is another case where we show that it really works out very well. You have a very quick increase of desperane if you use that technique, metabolic flow technique. And then if you want to switch off the withdrawal of the anesthesia, you can turn off the vapor 10 minutes before end of surgery, and then in the recovery room you can do whatever you like. That is this slide, as you've seen before. You can do this the whole day. It works out very nicely. As you see here, we start up at 7:54, and then here we end up at 16:54. We do this all the time. Quick changes, everything with low flow, closed circuit, nearly closed circuit anesthesia. You can do also an inhalational anesthesia and then switch to desperane is also possible. And thank you for your attention, and a little bit of videotape. I need the audio, please.
What can your dog do? Fergus? Bud Light. Bad dog.
Fresh, smooth, real.
Okay, so you can use a circle system, very intelligent. Thank you very much for your attention. If you like to have a CD-ROM, here's again my email address. If you send me an email or send me a mail, I will send you a CD-ROM. I have one with me in German, but I also have in English language some CD-ROMs. And one more time, thanks again. Open for questions. Any further questions?
The traditional teaching when you use sevoflurane on closed is not to go down the flow rate less than 2 liters per minute. So what is your take on that? That is one question. And the second thing is, if you want to suddenly increase the depth of anesthetic,
Please.
if you suddenly want to increase the depth of anesthetic when a clinical situation needs for you to increase this depth of anesthesia very quickly.
Okay.
So you will have to increase the flows so as to be able to attain the inspired concentrations fairly quickly.
Okay.
Yeah.
So the first question is, are you allowed to use sevoflurane with lower fresh gas flows than 2 liters? As far as I know, in Europe, there is no restriction of the fresh gas flow for sevoflurane, and in the United States, there was in the past a restriction of the use of sevoflurane with a flow lower than 1 liter. But this is all skipped because right now there are no data out there. There's no evidence that sevoflurane, that the use of sevoflurane with low concentration produces clinical relevant concentration of gases which may harm the patient, so you can't measure anything. The most important part using sevoflurane with low concentration is having no verolyme. So what the Americans always used was verolyme, and that verolyme is very dangerous because it really produces compound A and produces carbon monoxide, and therefore you should not use sevoflurane with verolyme. In Germany, verolyme is not available anymore, and in Europe, I think overall you cannot buy any verolyme So I think you are pretty much safe if you buy normal absorbent from Smith or Draeger or whatever you like to choose. It should contain sodium and calcium hydroxide, but no beryllium.
But in the UK guidelines, they say that if you're using sevoflurane,
Yeah.
should not use flows less than 2 liters per minute fresh gas.
Who says that?
The UK recommendations, United Kingdom.
Really? I haven't read that. It's old. I think it's not actual.
It used to be the recommendation.
It's the actual recommendation?
It used to be, I don't know the present situation.
Okay. I don't think that this is really evidence-based. There is no evidence base. Okay, now the second question was, how would you get a deeper anesthesia in a short time? I have a small chart for this, which I skipped actually during my talk because of the time, but I can just go there. We find it real quick. There you are. So in my practice, I do this. I inject a little bit of propofol, like 20 to 50 milligrams, like 2 to 5 cc's. And then I increase the fresh gas flow up to 0.5 to 0.75 liters per minute and turn on the vapor up to 18. For example, if you use desflurane. And then after I have the increase of MEG, which I would like to have, I decrease back to 0.35 liters per minute and turn the vapor down to 12. The increase of anesthesia depth with volatile anesthetics with sevoflurane is very easy, and you can do that. You can increase the flow, and then you have very quickly very high concentration of sevoflurane in the system. But if you think that humidity and heat in the circle system is important, then you don't use higher flows because you wash out the humidity and the heat out of the circle system, and you want to keep the air which the patient inhales in your circle system, you want to keep it warm and you want to keep it humid. And if you use high flow just to get a deep anesthesia in a short time, then you wash out all the water and you wash out all the heat out of the circle system. So in my opinion, it's better to use propofol for an injection, so you have very quickly a very deep anesthesia within 30 seconds or 45 seconds. Then you increase the flow a little bit, just a little bit. You have a slow increase of the inspired and expired gas concentration in the system. And then when you establish the concentration you need, you return the flow down to the level you need. I think that's the best way of doing it, at least what right now I know from the evidence in the literature. But I will look up the things from Great Britain. I will look that up, definitely.